Hello everyone, we are from SGDB 8 and in this occasion, we would like to present our student project entitled Stevens-Johnson Syndrome. Here are our team members. Hello, my name is Niputulan Prasanti and my last 3-digit number is 138. And now we're gonna discuss about the background. Stevens-Johnson syndrome is a rare, acute, and fatal disease caused by an immunologically mediated skin adverse reaction characterized by epidermal detachment and mucosal loss accompanied by systemic symptoms. This disease is associated with a mortality rate ranging from 15 to 25%. Immune dysregulation, active malignancy, and genetic predisposition are risk factors for developing Stevens-Johnson syndrome. The most common causes are medications, particularly antimicrobials, antiepileptics, allopurinol, and non-steroidal anti-inflammatory drugs. Stevens-Johnson syndrome has significant levels of morbidity and mortality. Knowledge of early diagnosis and treatment is essential in achieving favorable outcomes for patients.
Hello everyone, my name is Putudi Sitirananta with student ID number 021. So today I will explain about the problem formulation, purpose, and the benefits of our student project. So the problem raising from presented background can be formulated as follows. The first one, what are the definition and epidemiology of Stevens-Johnson syndrome? What is the pathogenesis of Stevens-Johnson syndrome? What are the signs and symptoms of Stevens-Johnson syndrome? What are the risk factors of Stevens-Johnson syndrome? And the last one is what are the diagnosis and treatments of Stevens-Johnson syndrome? So we have two purposes here. The first one, the general purpose of the student project is to give the reader an information about Stevens-Johnson syndrome. And the second one is the specific purpose to describe the definition and epidemiology of Stevens-Johnson syndrome, to explain about the pathogenesis and of Stevens-Johnson syndrome, to know about the signs and symptoms of Stevens-Johnson syndrome, to describe the risk factors of Stevens-Johnson syndrome, and to interpret the diagnosis and also the treatments of Stevens-Johnson syndrome. Next slide. So now it's the benefit. We have two benefits here, practical and theoretical. The practical benefit is to provide this information to the readers so they may understand about Stevens-Johnson syndrome, and the theoretical is to give information and knowledge about Stevens-Johnson syndrome. That's all from me. Thank you.
My name is Beningkinan Kalisa with the last 3 digits of my student ID number R152. I will continue the explanation about the definition of Stevens-Johnson syndrome. So, Stevens-Johnson syndrome is a dermatological emergency characterized by widespread skin damage or shedding. It was first described by Stevens and Janssen in 1922 and is often considered a more severe form of erythema multiforme. Clinically, it manifests with a sudden onset of flu-like symptoms followed by a distinct red or purple rash. This rash can progress rapidly and vary in severity from mild to extensive skin detachment. Stevens-Johnson syndrome is a medical emergency that typically requires hospitalization. Treatment focused on identifying and eliminating the cause, tending the wounds, managing pains, and reducing complications as the skin regenerates. Recovery can take several weeks to months. So that's all for me. Thank you.
Okay, I will continue the presentation about the epidemiology of Stevens-Johnson syndrome. But before that, let me introduce myself. My name is Tabitha Trinanya Brusmiring with the last 3 digits of student number 232. So, Stevens-Johnson syndrome, or SJS, or toxic epidermal necrolysis, or TEN, is estimated to affect 2 to 7 out of 1 million people each year. Stevens-Johnson syndrome is 3 times more common than toxic epidermal necrolysis. Stevens-Johnson syndrome or toxic epidermal necrolysis can affect anyone with a genetic predisposition, which is people of any age, gender, and race, although it is more common in the elderly or women. Patients with malignant disease, especially a hematological cancer and human immunodeficiency virus or HIV, are also at higher risk of developing SJS or TEN. The mortality rate of TEN is also 50 to 10% in SJS and a combined mortality rate of 30%. Older age, over 70 years, and comorbidities were associated with higher mortality rates. SGS or TEN is a group of diseases with high morbidity and mortality rates. Previous study report a mortality rate in SGS of around 19.4% to 29% and TEN around 14.8% to 48%. Genetic factors including human leukocyte antigen or HLA phenotype lead to an increased risk of Stevens-Johnson syndrome or toxic epidermal necrolysis following exposure to aromatic anticonvulsant and allopurinol. Genetic studies have identified population at high risk of TN or SGS. Family members of patients with Stevens-Johnson syndrome or toxic epidermal necrolysis should be informed about the risk of developing this disease and should be careful when taking medications associated with this disease. That's all that I can explain about the epidemiology.
Okay, I will continue. My name is Iputu Pranadia Vidasagara with the last 3 digits of my student number are 059, and now I'll explain about the pathogenesis of Stevens-Johnson syndrome. So, based on the classification, Stevens-Johnson syndrome is one of type 4C hypersensitivity reactions with major effectors, namely cytotoxic CD8 T cells, CD4 T cells, and natural killer cells. Key initiators that can stimulate immune reactions in Stevens-Johnson syndrome patient consist of drug antigens or metabolites, genetic HLA predisposition, and TCR repertoire. Stevens-Johnson syndrome has a mechanism of pathogenesis that begins with certain specific HLA alleles and keratinocytes or antigen-presenting cells bind to drug antigens and present them. Then, it will be recognized by TCR and activate CD8 CTLs, also downstream expression of cytotoxic signals. Skin homing CTL proliferates, producing cytotoxic proteins and cytokines, which are capable of arousing extensive skin necrosis.
Okay, let me to introduce myself. My name is Putu Parta. The last 3 digits of my number is 080. Okay, the key of Stevens-Johnson syndrome is circulating immune complex and T cell activity can cause tissue damage and systemic symptom. Circulating immune complex can form when heptens or antigens bind to carriers and stimulate specific immune response. Circulating immune complexes can settle and cause tissue damage in the skin and mucosa areas due to complement activation, inflammatory reaction, or T cell activity and mediators that it produces. T cell activity can also cause tissue damage by inducing apoptosis of keratinocyte. And then tissue damage in Stevens-Johnson syndrome can lead into systemic symptoms such as hormonal stress, increased insulin resistance, fluid loss, glucosuria, hypoglycemia, immune function failure, infection, and thermoregulation failure. That's all from me. Thank you.
Let me introduce myself. My name is Rian Endra Putranto with the last 3 digit number is 094. Let me explain about the sign and symptom of the Stevens-Johnson syndrome. Early sign of Stevens-Johnson syndrome may not be specific. The initial sign of Stevens-Johnson syndrome may be flu-like symptoms, including fever, sore throat, coughing, and joint discomfort. Usually, the symptoms present manifestation on the skin for several days. Typically, the rash begins on the upper body and moves swiftly to the face, arm, legs, and other part of the body, including genitalia. Involvement from the buccal genitalia or mucosa in the eye present more than 90% from all patients, and in several cases, respiratory and digestive symptoms are also affected.
Okay, permission to continue the presentation. My name is Gide Vivikan Rusdi with 3 last digit number 190. Today I would like to continue to the signs and symptoms of Stevens-Johnson syndrome. So there are 3 main symptoms of Stevens-Johnson syndrome. The first one is ocular involvement. Ocular involvement occurs quite often. Start from acute conjunctivitis, eye saccadium, erythema, eye crust, and ocular discharge, and develop into form pseudomembrane or corneal erosion. And in severe case, ocular involvement can develop into cystorizing lesion, symblepharon, fornix shortening, and corneal ulceration. The next one is skin involvement. Symptoms that can occur on the skin of Stevens-Johnson syndrome patients are appearing rash that starts to develop into erythema, papule, vesicle, and bulla. On the other hand, pathognomonic sign that appears are target lesion or targetoid lesion. Peeling of the skin is common in this syndrome, characterized by Nikolsky skin positive. Peeling occurs most often in stressed areas of the body such as the back and the buttocks. Okay, the next one is mucosa involvement. Abnormalities in the mucosa mostly involve the oral and esophageal mucosa, but can also involve the mucosa of the lungs and genitals. In the oral mucosa, Abnormalities can include stomatitis on the lips, tongue, and buccal mouth mucus. Stomatitis could be worsened by appearance of bulla that can rupture anytime and can leave marks such as black crust on the patient's lips. In addition, lesions can also appear on the oropharyngeal mucus, bronchotrachea, and esophageal, making it difficult for sufferers to breathe and digest food, as well as in the genital urinary tract, making the process difficult for micturition or urination.
So there are a few factors that increase the risk of developing Stevens-Johnson syndrome. The first one is genetic factor. HLA or human leukocyte antigen, all types can lead to an increased Stevens-Johnson syndrome when exposed to aromatic anticonvulsants and allopurinol. Second one is family history with Stevens-Johnson syndrome. Family members of patients with Stevens-Johnson syndrome should be informed about the risk of developing this disease and should be careful about taking medications associated with this disease. The third one is drug use, such as anticonvulsants, which are carbamazepine and phenytoin, allopurinol, sulfonamide, which are cotrimoxazole and sulfasalazine, antibiotics such as penicillins and cephalosporin, paracetamol or acetaminophen, nevirapine, and NSAIDs, mainly oxycodone type, and the last one is contrast media. The next one is HIV infection. Stevens-Johnson syndrome is much more likely to occur in people infected with HIV, with an estimated incidence of 1 per 1,000.
Hello, my name is Misal Karna Putra and my last 3-digit NIM number is 167. I will explain about diagnosis of Stevens-Johnson syndrome. The diagnosis of Stevens-Johnson syndrome is made by an ophthalmologist or dermatologist during a thorough medical evaluation that includes a physical examination and history. The clinical picture will show abnormalities in the skin, mucosa, and eyes. Meanwhile, anamnesis is aimed at finding out the causative factors, and the most frequently carried out anamnesis is a review of treatment history because this is the most common causative factor. Here are some tests to diagnose Stevens-Johnson syndrome. First, skin biopsy. The dermatologist will use this method to ensure the diagnosis is correct and rule out other possible causes. A healthcare provider will take a skin sample for laboratory testing. Second, culture. Culture laboratory testing will be carried out by taking skin fluid or tissue samples. This is done to rule out the possibility of infection. Third, imaging. To check for pneumonia, your healthcare provider will ask you to undergo an examination process such as a chest x-ray. This goes back to the symptoms you are experiencing. The last one is blood test. This is used to confirm infection or other possible causes. Anemia can be found in several cases with bleeding. Leukocytes are usually normal or slightly elevated. There is an increase in eosinophils. IgG and IgM level can be elevated. C3 and C4 are normal or slightly decreased, and the presence of circulating immune complex can be detected. On histopathologic examination, necrosis in the epidermis can be found partially or completely. Intracellular edema in the epidermis, swelling of the endothelium, and erythrocyte coming out of the skin. Immunofluorescence examination can show IgM, IgA, C3, and fibrin deposits. Thank you.
Greetings everyone, I'm Dewi Prameswari with the last 3-digit of student registration number is 101, and I'm going to talk about the treatment of Stevens-Johnson syndrome. Stevens-Johnson syndrome has the possibility of rapid growth and severe clinical manifestation. Thus, it requires ICU or burn care unit. It also requires a close monitoring and breathing control by intubation and mechanical breathing. The patient should be included with oral care with periodic irrigation with antiseptic solution or mouthwash, and also using lip balm such as Vaseline. We also have to manage fluids, electrolyte, and nutrition of the patient. We also have to control for hospital-acquired infections such as Staphylococcus aureus or Pseudomonas aeruginosa infection. Wound treatment is also important to maintain thermal regulation, prevent excessive loss, prevent secondary infection, and reduce scarring. According to the UK standards, we should not apply pressure to the skin, we should minimize moving and placing the patient, minimize the use of sticky tapes. Suspect of the Stevens-Johnson syndrome should be evaluated by ophthalmologists as soon as possible. And lastly, several pharmacology agents can be used to treat the syndrome, such as systemic corticosteroid, cyclosporin, IVIG with or without steroids, and etanercept. I think that's all from me. Thank you.
Okay, thank you for your time. Allow me to introduce myself first. My name is Wilson Eka Putra Tanuwijaya, with the last three digits of my student number being 084. I will be ending this presentation off with the conclusion. So, SJS is a dermatological emergency which is notified by skin damage spreading to the eye, mouth, and genitals. It was found in 1922 by Stevens and Johnson. This syndrome affects 2 to 7 people per million and is more commonly found in elderly people and women. The risk factors for this disease includes genetics, family history, taking a drug usage, and HIV infection, and is diagnosed via skin biopsy, culture imaging, and blood tests. This sickness is also easily treated by ICU or intensive care unit, oral care, fluid restoration, hospital-acquired infection control protocols, and doing base ophthalmology checks.